Good morning, everybody. This is Ziv Simon here broadcasting from Beverly Hills. Welcome to our live training, IGR number 3, the Implant Gold Rush Master's Course. So welcome, everybody. We're going to just get started in a couple of minutes. And when you check in, say your name, say where you're from. We have about 30 people now in the room. And as everybody is joining us, say hi to me. Tell me if you can hear me loud and clear. Again, this is Ziv. I'm excited to give you or give you, it's all a gift, IGR number 3. And in this live training, we're going to talk about aesthetic implants. We are moving on to higher levels of experience. Again, congratulations on taking the step to investing in yourself, investing in learning how to place dental implants, how to perform them, and get great results, grow your practice, and all this other good stuff. And thank you again so much for the opportunity to help you and for trusting me and Surgical Master in playing a role in your growth. So again, I'm excited to get started in a couple of minutes. If you're just checking in, let me know your name, where you're from, what time it is. Hi, Anthony from Melbourne. It's 11 p.m. I'll give you some good ideas before you fall asleep. So we'll have about 1 hour together. Anthony, you're the first one checking in. Looking forward to tonight. You have another aesthetic case on Thursday. Okay, cool. I'm excited for you. So in this training today, I'm going to talk about aesthetic implants, specifically the canine, lateral, and central, which are the aesthetic teeth or the aesthetic implants. And I'm going to be talking about a case where I placed 3 implants, 1 canine, 1 lateral, 1 central. And I wanted to show you how this case turned out. So I think this is going to be very, very helpful to you. Now, if you missed out on the previous training, not to worry, they're all recorded. IG2, Implant Gold Rush Live 1 and 2, posted in Speak CT. So as the master's program, go ahead. Now we're live training. Go ahead later on, whenever you want, go into Speak CT and log into the live sessions, and you'll see IGR 1 and 2. And of course, I'll post number 3 and all the other ones in the series. So this is available to you at any time. And you can also ask questions. Let's say you attended the session, you forgot to ask me something, no big deal. Just go into the live training recording and post your question there. I'm answering. And I think most of you, Raj, how are you, from Toronto? One of my favorite cities in the world. If you have questions, like and Raj knows, and a lot of other doctors participating in this course, we're almost 100 people. You can post the question at the bottom of any video. It goes directly to me as an email, and I answer pretty fast as long as I'm up. Okay, so watch these recordings. So as doctors are checking in, slowly started. First of all, we have Dr. Rashad Ryman monitoring here from his practice. It's a beautiful day here. It's 6 a.m., best time of the day, quiet, and starting to talk about the 33 steps of being a great surgeon. Last trainings, we talked about the first one, which was, as a surgeon, you need to be adaptable. You need to adapt to the circumstances that arise. You need to know some treatment alternatives. You can't get stuck. And that's a very important skill of a good surgeon, the adaptability. And we're going to work on that during the training. Then I also talked about the learning curve and honing your skills and learning to be great and getting great results. It doesn't happen overnight. Not even 2 nights. It takes time, and I called it last time the process of having active patience, meaning you need to do a lot of things, but you also need to be patient. And I gave you the example of a wax up approach versus a light cure approach that happens immediately. When you light cure a composite, within 10 seconds, the thing is hard. A wax up takes some time, takes some mistakes, takes some corrections and adaptations, and you need to be patient. Now, in this training, I'm going to talk about the aesthetic zone, and this is where another skill of a great dentist is important, the trait of having confidence. Now, when I talk about confidence, it's a factor of many things. It's a factor of your knowledge and a factor of your training and your experience and maybe some innate character. Some people are more confident than others. And I shared with you leading up to this training and in several of our promotions, when I talked about the implant gold rush, I talked about my own experience, and I was not always as confident as I am today. Okay, so I learned to develop my confidence. I mentioned to you before that confidence is like a muscle that you can grow with time if you do it in a smart way, in a safe way. And when I talk about confidence, it's not tooting your own horn and pounding on your chest and telling people that you're great. Okay, that's not confidence. That's quite the opposite. That's lack of confidence. You need to say things. You need to be cocky and obnoxious. If you feel that you need to be confident, that's not the case. Confidence is a quiet skill or a quiet characteristic. So focus on quiet confidence. Let your results speak for themselves. Let other people toot your own horn. Now, I'm going to give you a lot of tricks how to show your confidence, not in a cocky way. And if you think about what patients want in a doctor, there are a lot of things that are important, like being humane and caring and empathetic and confident. Patients are looking for confidence in a doctor. And you cannot fool people, too many people, all the time, because confidence has to come from within. And we're going to work on that. That's a very important skill, especially when you're dealing with the aesthetic zone. A lot of patients have fear and insecurities about losing teeth in the front or teeth in the aesthetic zone. And by you having the confidence, that's going to help. It's going to help with the trust of your patients in you as their surgeon. So, I've learned over the year, don't focus on telling patients that you've done 3 in your lifetime and you're 1% success. That's not the case. You have to say things that present you as a quiet, confident doctor, and saying things like, we've had great success. We had a lot of happy patients utilizing this technique, or we had a lot of happy patients that were able to smile with confidence and speak and chew and function properly after providing this type of treatment, as opposed to saying, we've treated 3,000 patients and had 99% success rates. And this is something you learn over time. But I will give you some tips and tricks to show your confidence. And also, throughout this training, you're gaining knowledge, you're gaining experience, and that will do great to your confidence. And in the next training, I'm going to keep going and talking about the guidelines, the steps, the frameworks that are important for you being, okay? So again, congrats on joining IGR. We're going to talk about aesthetic implants. We have our chart on the right-hand side. Feel free to leave any questions while I speak. Not a problem. I'm going to answer questions, but if you have a pertinent question during it, so you just feel like putting something in there or communicating with the other doctors on the line, on the call, let me know, okay? So let's get started talking about aesthetic implants, specifically the canine lateral incisor. I'm going to talk about how we deal with picky patients, or what we call demanding patients, and talk about the staging of the implant, the immediate placement versus the delayed approach. What's better in which case? What are some criteria to help you decide how to do this? Of course, I'll show you one case that has it all, and you'll be able to ask me anything. Why did I choose this approach, or why didn't I go a different way? And hopefully I have a good answer for you. I'm going to show you some of the planning in the aesthetic zone. I'm going to point out to what's critical so you can take the information from this training alone and be a better planner. Be a better planner. I want you to be successful, and in the aesthetic zone, there's not too much leeway when it comes to the positioning. Any mistake, any malpositioning, and I'll show you some of my mistakes, by the way. This is not, by no means is it the perfect case, but I'm going to show you some of the mistakes that I've made in the planning process that trickle down to the surgery and how I handle that. And I think this is going to be really interesting to you. I'm going to talk about the immediate provisionals, or provisional. We had 3 immediate provisionals in this case, and how they were fabricated, which I think is a great thing to learn. And I'll show you some of the problems that I've had in this case. And at the end of the presentation, if you survive this one, it's only about an hour long, or maybe a little bit short of that. We're going to talk again about how to charge. Last trainings, I talked to you about how much to charge for a bone graft and membrane and the reconstructive process. I talked to you about how to charge for an implant, and I showed you some formulas. And also last training in IGR number 2, I showed you, or talked about, how much to charge extra for an aesthetic implant. So if you didn't watch it, or if you're watching the recording of IGR 3 right now, go back, watch them. They're all posted. And that was really practical information. So in this one, at the end, I'm going to talk about how much do we charge for CGI, for adding the guided procedure. Do we give it away? Do we charge just our cost? Do we charge more? I'll talk about that. Okay, so let's get started. Welcome again, everybody. And I'm going to talk about this case where this patient, about 69 years old, maybe let's call it 70 years old, around there, from Beverly Hills, California. That's where I practice. For some reason, have the reputation here in Beverly Hills of having very picky patients. And I wanted to explore this topic of picky. I believe, I truly believe that patients all over the world, all over the, let's call it the industrial world, are pretty much the same. They have the same wishes and desires and expectations. It's just they don't always have the right doctors or the right technology available. But I believe that in essence, people are just exactly the same. They have their own needs. And when I thought about the concept of having a demanding patient or a picky patient, to be honest, I don't really know what it means. Because when it comes to the aesthetics, when you're replacing a central implant, everybody's picky. You would be picky, right? If you had needed, heaven forbid, needed to replace a tooth in the aesthetic zone or any tooth, you would be extremely picky. You would look in the mirror, you would look at different aesthetic considerations, and you may have a little bit of anxiety. So my advice to you, look at every patient. Have a split personality as a surgeon. Don't have two hats. Don't wear two hats. One hat for the picky patients, one hat for the non-picky patients that are, and I hate to say this word, but let's call them, let's say somebody who is a farmer and doesn't care if he's missing a front tooth and doesn't care about a papilla or a discrepancy in the gingival margin. And no offense to farmers. Farmers are one of the most successful people in America and deserve the best, and like any patient. But as an example, my advice to you look at every case as an aesthetic case. Even if the patient is very easygoing and nice and is very reasonable about the outcome, reach for the top, reach for the best aesthetic outcome, because that's the only way that you'll be able to grow and be able to deliver to those really, really picky patients that, we'll talk to you about papilla height and soft tissue asymmetry and things like that, okay? So don't wear two hats. So demanding patients are all of our patients, no exception. Yes, there will be some patients that we call exacting, that look in the mirror and they show you pictures of actors and actresses, and they show you smiles from a magazine, and they want this and they want that, and they're not reasonable, and we call them picky. And maybe we call them picky or demanding because they stress us out a little bit. But in any event, you need to be ready to treat every case as an aesthetic case. And it's not limited to Beverly Hills. Here's Rodeo Drive. And it's not just, I practice in 4 countries: Israel, Germany, Canada, and the United States. And I've traveled the world, and I've talked to dentists from all over the world. Doctors, it's all the same, okay? So in the Implant Gold Rush, we will own a mindset that is aimed towards the best possible results. And that does not mean that every time we'll get a great result or we'll get a perfect result. Actually, that's relatively rare in the aesthetic zone. There's always something that will take away from the perfection, but this is going to be our goal, and we're going to start understanding what's reasonable to expect. So this patient, let's call her a Beverly Hills patient, has pretty much, has all of her teeth restored, replaced with implants, with veneers and crowns. There's not one tooth non-restored in her mouth. And this time she was referred to me because of a canine, an upper right canine that failed to be replaced. So at the slide, you can see some inflammation between the canine and the lateral. You can see some bleeding on probing. Before we get to the replacement, it's some of the specific details of the. I want you to look at the big picture, okay? Don't just hone in, just take out the tooth, put an implant in there, miss out on a lot of important details, which is one of the big mistakes a lot of dentists are experiencing. This patient has excessive soft tissue. I think you can tell that the zone in tissue is pretty extensive, not just in the anterior maxilla, also in the back. She has some tori and exostosis. And if you took our crown lengthening course, you know that many times this type of presentation comes with short teeth, with abnormal teeth proportions. So there's a pretty good chance, and I can't tell because all the teeth are already restored, and this patient is 70 years old. I was not born when she had her first dental treatment, but there's a pretty good chance when you see that this patient had some sort of delayed eruption. And by the way, to have patients with delayed eruption having teeth replacement, you have to be very careful how far you submerge the implant. There's a mistake where we submerge an implant too shallow, and I've done this in this case. I'm going to show this to you in the next. The tooth that needs to be replaced, if you're looking at a previous implant that was placed to replace the lateral incisor, and I'll talk about this implant and how it was done later on. But look carefully, you see that the crown developed a secondary caries lesion, pretty much undermined the whole crown right around the post. And what are the options? I think the best option is to replace the tooth. I know it's a relatively long root, but the root structure is compromised. There's some internal or external root resorption right at the tip. believe that this tooth is worth saving with crown lengthening. Two structures, too compromised. There's a relatively large post in there. So the best option is to have this tooth replaced with an implant. Now, looking at the adjacent implant, don't be a kind of living in a bubble or thinking just about the tooth that you're extracting. Always look at the adjacent teeth. So this patient has experience with implants. She had this implant done about 7 years ago, or seven years before she saw me. I think you can tell that this implant is a little bit skewed to the distal, which is actually not a big deal in terms of the restorative process and not a big deal for this patient when the implant was done. But once an adjacent implant needs to be done, you are impinging on the restorative space, which tells me that anytime you're placing an implant, don't just think about the specifics of this case. That's very, very important. But think about what is going to happen if this patient loses an adjacent tooth, which is very likely, which is happening in this case. And what if she's going to have multiple adjacent implants? The spacing is going to be critical. So the more accurate you are, the better it is in terms of the future implant placement. And I'll show you what happened here for implant number 7. I think you see that quite adequate information. And speaking of demanding patient, this patient came in and she says, listen, I heard you are an expert in that, and I want the smile technique. This is how I had number 7 done. This is a technique. If you're not familiar with it, I'm just going to briefly talk about it. Basically, it's a technique developed by Dennis Shanalek here in Santa Barbara, who is a periodontist, who's a real master clinician. And what he does, and what he calls the smile technique, is basically an extraction and an immediate provisional. That's all it is, the smile technique, and he kind of branded it, and people want that. Okay, so basically what he does, he extracts a tooth, places an immediate implant, makes a chair-side provisional that is nicely adapted to the implant and nicely adapting to the tissue, develops a really nice emergence profile and molds the tissue towards the final restoration. He charges a bunch of money for that. Very costly to go have it done in Santa Barbara. So she had it done before. Now, she did not feel like driving to Santa Barbara 2 hours from Beverly Hills and having it done. And she asked her dentist, who else does the smile technique? So the patient was referred to me. But I told her, I do the smile technique. I do it differently. I'll do it differently. I'm not making the provisional chair side. I'm a periodontist. I don't enjoy dealing with acrylic and dealing with emergence profile. I prefabricate my provisional, which we're going to learn in this training. And I don't think it set well with her. I don't think it set well. I told her the fees for that. I told her it's actually a little bit more costly than the smile technique. Why? Because we are pre-making things and we're using a process called computer-guided surgery and this and that. And I tried my best to create value, but I did not do a good job. Okay, how do you know that I didn't do a good job? It's when a patient does not proceed with treatment. It doesn't mean that the patient did not like you, didn't like your practice. All it means is that this patient did not develop enough trust, enough likability to be treated by you. Okay, don't take it personal. Take it as a feedback. Take it as a failed experiment. Okay, any experience in life, any experience in our clinical practice, don't be dramatic and look at it as, oh my God, I failed and my patient left me and went to somebody else who's better than me. That's not the case. All it means is that during your encounter with the patient, you did not deliver enough value for the patient to stay. It's beyond the fee. It's not just the fee. You may have quoted the fee that was maybe a bit high or maybe beyond what the patient could afford at the time. But in reality, it comes down to value. And although I analyzed the case well, and I looked at all the issues, and of course, you can see the discrepancy in the papilla. but she ended up going to another surgeon, so I failed and had the tooth extracted and had a removal replaced. And that really shows you that even what we call demanding patients, they're not always that demanding, and they'll do what their surgeon tells them to do, or they follow the instructions. And luckily for me, the patient came back. Okay, so she came back after the tooth was already extracted. All this inflammation is gone. Some of the tissue has shrunk away. You can see now that the tissue level of the interproximal tissue is now level between mesial and distal compared to started. Okay, so when a patient leaves you, they may come back. Okay, I don't want you to. They don't come back. Look at it as if there's something you didn't know about this patient. You could have done it better. Okay, so this patient came back, and she said, "Okay, now I'm ready. I'm ready for my my smile technique. I'm ready for my implant and my immediate provisional." And I said, "Okay, no problem. Let me show you what the workup is. Let's look at the site, and we can see a pretty wide band of attaching keratinized tissue, which is great. Usually canines in the maxilla have maybe 1 or 2 millimeters of attaching keratinized tissue. She has about 3 or 4, a bit more. Reasonable papilla height. She has already. So I'm going to start my workup, in this case, taken a few months after the tooth was extracted. So she went and saw an oral surgeon who was really excellent. It was one of my colleagues here that I work with, that I refer to. She found him, had the tooth extracted, grafted. Hey, came back with a great site. Thank you so much. Makes it actually a little bit easier now for me. Now, again, don't focus only on the implant site. Okay, look what's around, not just look 2 teeth around. You can start seeing an open margin, maybe some secondary caries developing on the central incisor, short root, long post. This cannot be good. Okay, so we're going to look at this case, look at this tooth a little bit later, but I'm going to focus on planning what came with and looking at the soft. Very, very reasonable. She has a very low scalloping of the tissue. Okay, this is what we call a low risk case. Okay, if you have a patient that has high scalloping, meaning very tall and thin papilla, very easy to lose them. If they're relatively short and blunt, good for you. The teeth are short. We have some room. We have some room in terms of losing some tissue. So this is just a great case to start with. So what is the next case? What are you doing? Are you going to take out your implant drill an osteotomy, place an implant, make it provisional? No, that's not how you create value and how you deliver great treatment. You need to work up the case. I hope you guys are checking out CGI in the next training. I'm sorry, next training is, we're going to start talking about complications, which is going to be a great part of the live training. But we're going to also start next week with the CGI live training. So we have 6 trainings on that. So do yourself a favor. We shipped already the packages and the products. They're on their way. We're shipping out the scrubs on the 23rd. But if you still did not get it, let us know. And other than that, you can still plan your cases in CGI Box. I provided the link, so you can go to the link and you can start planning, because we're going to get started with CGI Box training next week. Okay, so the next step for this case in today's training is to start the planning, and really the planning starts diagnostic, wax up, very not the most sophisticated, beautiful here, but it'll do the job. And I'm going to start with that, the diagnostic wax up that is a full contour. Okay, pretty good idea of how this tooth is supposed to look like. Okay, and looking at the contralateral canine, I'd like them to match, to be honest. I'd like them to match if possible, if the occlusion allows them. And in order to plan a guided case, you need to have a model. So you have the wax up model here on the right-hand side. Here's the wax up, but you need to duplicate it. And what you're submitting to the company or what you're optically scanning is the duplicate. So once you have a wax up, the patient needs obviously a CT scan, which you'll get as a DICOM file. And then you need to merge both of these data sets. So the wax up plus the DICOM allows you to work. So this is a snap software. Okay, again, we're going to work on that in CGI Box. You get the experience. You'll start planning cases. You'll start getting frustrated with that, because if you're not frustrated, you're not learning and you're not challenging yourself. And if it's going too easy, okay, let's take you to the next level. Okay, so this is what I did here. Okay, Raj, no problem. You leave, catch up with us later. You see the you see the recording. No problem, Raj. So this is what's going on. You now have in your software, you have the CT scan, you have the wax up. I also incorporated a photograph. I took a photograph of the wax up because I wanted to see the contrast. I wanted to take a look at the exact emergence to make some good restorative decisions in terms of the placement. And now I'm going to go through a process that is relatively short of deciding how to place the implant. Okay, so this is what we call the three-dimensional view or the 3D view. And if I look at the cross-section through the implant, now you can tell where the ridge is, outline of the wax up here in white. You can see the soft tissue outline, the depth of the ridge. You can see obviously the bone. You can see the outline of the alveolar ridge. It's a pretty hefty ridge. Okay, very thick, very nicely regenerated. And you can see the buccal plate. It's pretty much intact. So what I typically do in these cross sections is I adjust the buccopalatal position. Now, like we talked about in the previous training in IGR number 2, you can move the implant bodily to the palate to create screw access right in here, or you can tilt it. You need to look at the distance to the buccal plate, which is a little bit thin to my liking, but well, technically there should be enough space mesiodistally. It's in a sense that we have an implant next door that is a bit, let's call it double parked, okay? It's placed a bit too distal, not badly, not malpositioned, horribly malpractice type of thing, but it's a bit too distal to my liking. So that's going to limit me in terms of my mesiodistal positioning. And when you're dealing in the guided world, when you're getting into CGI, it's not just the surgical space. Many times, it's how the restorations, the adjacent restored, and that allows you in a very specific location that basically forces you to place an implant that is not exactly in the middle. Okay, because if you're going through the guided process, you're working through a tube, and this tube has to fit between the adjacent restorations. Okay, so these are significant challenges that we have to do. So I'm going to go through a process of planning and tweaking and retweaking, and at the beginning it'll take you about 2 hours, but slowly but surely you'll find that there's only one position. There's really only one position that is safe from the adjacent teeth, that is in the right apical coronal position, that is in a screw retained position, which I critical if you can reach it. And with canines, we typically can, because they have a much more pronounced cingulum. And I believe that in this case, I could probably go a little bit more to the palate. Okay, we don't want to go too much to the palate, because then the tooth, by definition, will have a huge cingulum. The patient will feel the discrepancy in size, and it'll be a little bit uncomfortable. But if I look at the position that I chose and I look at the cross section, I too close to the buccal plate, probably around a millimeter. I'd like to be about 2 millimeters away. And now looking back, I had quite a bit of leeway, so I could very, very easily, I could have moved this implant to the palate, maybe a millimeter. I would still be okay in terms of screw access, but I would have been also safer in terms of the buccal plate, okay? So that's the beauty of guided surgery. You can go back. Your mistakes are just in front of you. Now, this is not a detrimental mistake where this case is going to fail, but we need to take some precautions, okay? In terms of the apicoronal position, I measured 3 millimeters, but I measured 3 millimeters more on the palatal aspect. You want it to be more on the buccal. So there was room to submerge this implant maybe a little bit more, maybe 1 more millimeter, and that's very, very critical. Now, if you're prefabricating a provisional, you cannot change the implant position, or you shouldn't, because then the provisional is not going to fit. Then you have to remake it. Okay, so I'll talk about it a little bit more when I talk about the provisional delivery. But this is that kind of tricky, and really shows you and shows me the how humble you need to be when you're dealing with the aesthetic zone. There are so many decisions that you need to make in 3D positioning that if you don't pre-plan it, we say good luck, because to get it right in all 3 dimensions, freehand, it's not happening. Even guided, you can tell that I made some planning mistakes. Could have been a little bit more ideal. Okay, so spend enough time to make sure that your implant is properly positioned, and then depending on the software that you're using, the software will give you a proposal of a surgical guide. So I'm going to spend looking at the virtual guide and looking and seeing where this tube is located. You can tell the tube, so it's almost bordering the premolar, okay? So sometimes we need to move it a little bit more to the distal, but there's really a fraction of a millimeter. This tube has really only one spot to fit in, okay? And the implant is not going to be dead on in the center, so we're going to take a look. Okay, so here is our, okay, so we inspected and we pay for it, we order it. You want to make sure that the guide is supported by almost a full arch for stability. If you're designing your own guides with Blue Sky Bio, totally fine. In CGI Box, you see exactly how I design it and how the outline works. And if you like spending the time and doing that, that's great. You can get to a point where you print your own guides. I don't recommend it because it's a lot of time. It's a lot of money in terms of the printer, but not so much the printer. It's mostly the upkeep and the plastic that you're going to use, the material and the repair. I don't think it's worth it, but I leave it up to you. So once, my preference is once you have a virtual guide planned, you have an STL for that, you can simply order the guide, have it delivered to your office. And that does not mean that you keep it in the drawer all the way until the proceeding. You want to take a look at it to make sure that it fits. There's no flush in there. There's no plastic material, that the tube is well secured. There's sometimes seating windows. You see them here. So when you place your guide, you know that it's seated all the way. And basically now, before you schedule the patient, because this patient, remember, wanted smile technique. And what does the smile technique mean? Patient wants an immediate provisional. Now, and that's great, but I prefer to prefabricate the provisional. So all I'm going to do is take the surgical guide, take the models, take the wax, give them back to the technician, have him look at it, but I'm also going to provide them an implant analog of the specific implant that I'm going to use. It doesn't have to be the same length, but it has to be the same connection, the same diameter, obviously. That's the implant you're placing. And I'm going to provide them with the implant mount, and that's the mount or the component that delivers the implant through the guide. And these two will be connected. And what does the technician do with it? Basically, what the technician does, he or she places the mount, the guide, okay? So that's all before the surgery, doctors. Just want to make sure if you're just checking in with us right now, this is all done before the procedure, okay? All done before. So you place the fixture mount with the implant analog through the guide, and based off that, placing it on the model, creating some space where the fixture mount is supposed to fit, adding some plaster, you're basically getting a model. Now, the alignment is also very, very important. It's called timing, okay? So, and I'm going to talk about how we adjusting is basically the position of the platform, the position of the implant around its axis, and it's represented here in the fixture mount. You see there are 6 edges. It's basically a hex or hexagon. So you can know at any time what the timing is like. And I'm going to make this clear later on. So if you give this to your technician, they should fabricate a model and make a provisional of that. Okay, so we have a model. We have a screw retained provisional, nicely polished. Relatively small. You see, we can probably increase the cingulum, but this is just a provisional. And looking at the site, we have to have a provisional. We can book the patient for the procedure. We can talk about fees. We can talk about consents. We can schedule the procedure. And looking at the site, we have a lot of attached and keratinized tissue in all 3 dimensions. And that was a great case technique. Now, if you feel that you don't have enough, meaning you don't have enough attached and keratinized tissue, you'd like to bulk up the tissue, you can use a flap. But word of caution, we have an adjacent implant in here. You don't want to expose anything at this interface right in here. You don't want to, because once you detach the tissue, it may never come back. It may never come back. So my tendency is either use a papilla sparing technique. I showed this to you in the last training. You can do a papilla sparing only on one end. That's totally fine. Or you can use a punch technique, and after you punch the tissue, I actually measured it to be about 3 millimeters. So I know that implant at the bone level, which is basically where this soft tissue punch ended up being, I'll have about 3 millimeters of leeway or running room to develop an emergence profile. So here's our punch technique. Look a little bit too close to the premolar. I have to admit, it looks a little bit too close. I probably could have planned it a little bit more bodily to the mesial. But once it's planned, it's planned. Now, if I had seen a very significant problem with it, I would basically abort the guide. I would do it freehand, or I would reschedule the procedure. But let's see how this case worked out. Give me your honest feedback. Once you have access to the ridge, I would place my guide. I would start quick through the guide using the different drills in your protocol. Don't forget to take x-rays. Always take, even if you're doing a guided procedure and it looks straightforward and you have no fear and you have a lot of clarity, which I know you will have after you go through this training, make sure that you take an x-ray, okay? And x-rays in the canine region on the corner, it's not always simple to get an orthoradial x-ray, meaning an x-ray that shows you the exact space mesiodistally. And it's just simple enough to look at the premolar. You see that this x-ray is skewed a little bit because you starting to see the separation between the roots. So you need to train your assistants. That does not mean I'm touching or very close. It means that I'm another x-ray. You see, it kind of looks pretty close. So take a different x-ray. Sometimes it takes an x-ray of the premolars and now confirming that I have enough space. I think you can tell that the space is tight, but it's still at a safe distance. This is at the final osteotomy drill, meaning I took an x-ray with a direction indicator with the final osteotomy. So we have the space. So don't give up, okay? Don't give up. And now looking at the previous x-rays and saying, oh my God, the guided cuff, I'm going to drill by hand. Because if you do, you probably will mess it up. So just make sure that you take the x-rays. And if you did mess up the planning, that's a good time to find out before you place the implant, okay? So I completed my osteotomy using a sequence of drills, and it's time to place the implant using the exact fixture mount I gave the technician. And you want to make sure, of course, it's sterile. The implant is attached to it. You deliver it in slow RPM through the guide, no water irrigation. And we planned the implant to be timed like this. You see the hair, this is a straight line. He made a little he made a mark that should be perpendicular to one of the flat ends of the hex right in here. So this is one way to time. Why is timing so important? We say timing is everything in life. Timing is everything with implants. Why? Because if we have an implant that is mistimed, that doesn't have the right timing, which, by the way, does not make a difference. They can always be restored. But don't forget, we prefabricated a provisional that fits the implant in only a certain timing. So there are now, in this case, there are only 6 positions for this crown to fit. So I need to really be extremely accurate, not just in terms of the 3D positioning, meaning apical, coronal, mesodistal, buccolingual, buccopalatal, but also the timing of the implant. And the best way to find out the timing is by creating a mark right in here on the surgical guide. And that will time the implant, okay? So you can tell the premolar. We still have the distance here, okay? I don't want you to think this is the distance. The distance is right in here. We have enough bone, and that's really was really pretty close to the surgical space that I could work with in terms of doing a guided procedure. It could probably be a fraction of a millimeter to the mesial, a little bit, but not significantly. Here's the positioning right from the top, and you can tell that there is not too much leeway. You see the implant is now positioned with a healing abutment. And the reason I placed the healing abutment was I did test the crown, and I'll show this to you, but I did just tested the crown. I took it off, placed the healing abutment, sent the patient to the dentist because he wanted to be the one delivering the crown. But I definitely tested it in the chair. So basically what I did, I took the crown, delivered to me, and delivered it. And it really fit perfectly right after. There was a little bit of blanching here of the tissue, which is great, starting to mold the tissue, creating a better emergence profile. But I took it out, put the healing abutment on, and sent the patient that was just next door, had the dentist deliver, just in case there are any adjustments and contacts and things like that that I don't like to change myself, okay? These crowns, these temporary crowns are going to fit perfectly if you did the right plan, if they were done perfectly, and if you accounted for the timing, okay? So remember, timing is everything. If you have the right position of the hex, the crown is going. In a criticism for myself, I think we could have gone a little bit more screw axis to the palate, not compromise the buccal plate. More palatal is safer. The palatal bone is much more resistant to resorption, okay? So just be aware of that. But this case turned out really great. The patient, told me, I told you you can do this. I did not bother correcting her that I don't do the smile technique. All I do is computer-guided surgery, CGI, and a fabricated provisional. So everything worked out great. You see the provisional here. This patient wore this provisional for a year. She although the color is a bit off, but she was very, very happy with it. Okay, but a little bit after this procedure, you know, number 8 is kind of hurting me. Okay, and she was happy with the aesthetics, and although there's a little bit of a missing papilla in here, you see that right in here, but that papilla was missing to begin with. Okay, missing to begin with. Okay, so that helps. Picky patient that is not so picky, I guess. So she said, you know, my front tooth hurts, number 8. And you can see this tooth is a compromised tooth. There's a structure, a large post, a short root. It's not going to last for very long. So I told this patient, you know what? I don't see anything at the moment. I know this tooth hurts. It's probably cracked. It probably will be replaced at some point. Let me do the following. Let me complete a guided plan. You see, this is the old scan. I reused the scan, no problem. You see, it's before the number 6 implant was placed. Number 7 was from before, years back. Now, let me plan number 8. We're not pulling the trigger yet, but I'll have a plan ready in case this tooth breaks. What? A couple months later, maybe 6 months, 8 months later, she came back and she says, you know what? I need another implant. Actually, I need 2. I need number 8. I need number 10. 10 broke as well. Why is this happening? Why is this happening all the time? Again, side note, look at the x-ray of number 8. What does it mean? Does it mean that the tooth is touching the implant? It may look like it, but it's not. Okay, it's just the angle of the x-ray. So don't freak out on me. Take x-rays from different angles. Try to separate the roots, separate the implant from the adjacent root. You'll find out that it's not as close as you think, okay, or not close at all. But here's a great advantage of surgery. Okay, I did this case, it worked great for the patient. She was extremely happy, and she said, you know, my tooth hurts. No problem. We'll have a plan made. Whenever you need another implant, boom. All I need to do is press a button, ordering a guide. 4 days later, I'm going to get a guide. What we didn't know, that another tooth is going to break, tooth number 10. And what's the problem in that? I'm going to plan that as well. Now, before we get to the planning of 8 and number 10, why is this happening? Why is she breaking teeth? And why is she going to break more? Okay, the answer is in front of you, doctor. The answer is in front of you. Tooth number 8 failed, and tooth number 10 failed because this patient has a deep bite that is destructive. Okay, you know, it creates work, it creates production, it builds my practice, and I'm making money here. But I'm not happy because I don't like my patients to break their teeth. I know it's a kind of a conflict of interest, and we this is the source of our business. But if you're delivering crowns and veneers and they keep breaking and the patient keeps needing more and more implants, you know, it's your responsibility. You need to diagnose the bite, maybe put the patients through some ortho. Maybe there's nothing that can be done. Okay, give me some comments here. Maybe you would have done things differently, but the truth of the matter is that this patient broke a tooth and another one, and now needs 2 implants, broken beyond repair. Okay, this is just the pattern. So I don't think can or should extrude this tooth, do some crown thinning, save it, because this bite is going to be destructive to anything that we do, even to implants. Okay, from a restorative point of view, the implants will not lose integration, but you'll get some screw loosening, you'll get some other issues. Yes, you can splint things together, like Anthony's saying, absolutely. But I just want you to be clear about the reasons this patient, these types of problems are losing more and more teeth. Okay, so the plan number 8 and number 10, right in here, place immediate implants. Okay, again, there's nothing wrong if you don't feel comfortable as yet to go immediate. I don't want you to feel bad. There are certain advantages to that, but this patient really had all her implants done so far immediately. This patient has a certain demanding, exacting personality, And that's not to say that we should do what the patient wants, even if it's not indicated or not the right thing to do. But I want you to explore these options, and the best way to explore is to go through a guided plan. Okay, so my plan is to place 2 immediate implants for 8 and 10, and if possible, place immediate provisionals. I'm going to go through the same process we did before. I'm going to use an older scan. Nothing wrong with that, doctor. Nothing wrong. And you may ask yourself, so if this is an older scan, where's number 10? I'm sorry, where's number 8? 10 is here. 10 is here because the file was rendered before. Well, I asked the software company, the guided company, to extract or virtually extract tooth number 8 so I can look at the socket. Now, I didn't do it for 10 because 10 just broke. So I'm going to go through a planning process and start planning both implants, mesiodistally in the right position, buccolingually, or you can see the implant here. I'm using a relatively long implant, 13 millimeters. Here's the outline of the root. You want the implant to be a bit more to the palate, submerged enough, but we have some conclusions here. What is the conclusion? I can't go more palatally. It's not possible because the palatal bone is here. Although I have very thick soft tissue, the palatal bone is here. If I go too palatally, I'm going to basically blow out the palatal plate. We don't want that. I can't tilt the implant too palatally. Why? Because if I tilt the implant to the palate, I'm going to have the apex going through the concavity, which is a problem. I can't move it buccally, I can't tilt it. So the conclusion is that this implant needs to be cementable or needs to be using a tilted screw. And if you're not familiar with the tilted screw technology, I talked about it in the previous training. So go back and watch the recording, okay? In regards to the number 8 implant, ridge is a little bit wider. I have a little bit more room, and it looks like I can submerge it about good 3 millimeters, but the difference here is that I have the nasopalatine canal right here. So you see I'm bordering it. I'm not invading it, but it's right here in the border. I'm placing the implant a little bit more to the palate. Okay, I'm submerging it a little bit subosseous. And I have the outline of the socket. Okay, here's the outline of the socket. So here's I'm going to do some preventative grafting in here. Okay, so once I place the implant, and I can probably get a screw retained crown. Okay, so the planning process for this case doesn't take too long. Probably takes about 15-20 minutes because we don't have that much room. And initially it'll take you probably an hour, but it's super critical because we're going to prefabricate 2 new provisionals and going to place them. So if I'm not going to make the right decisions now, it's going to be a problem. Now, my concern, and I'll show you how it haunted me, my concern is that I used an old scan, number 1, okay? Number 2, I used the older impression that I had, okay? So that's important, okay? So look at the final plan, okay? This lateral looks like it can be either screw, cementable, or if the crown gets a little bit overbulked, it can this. And I recommend the access hole is through the buccal. Still make it screw retained because that's the only way to mold the tissue. Comes the time to place the final restoration, not necessarily the case. Now here, it's pretty cool. I used the patient's photographs and merged it with the scan so you can actually see the position of the trajectory of the implant. Okay? Plan is ready. What do we do next? We create a virtual guide depending on the software that you're using. This software is just a click of the button, which is my preference. Don't spend too much time planning your guides, doctors. Don't spend the time. There are more productive things that you can do with your time. But if you really are like a technology geek, like me, which I love technology and software and computers, but in terms of clinical practice, it's not worth for you to plan your guides and print them. But if you like to do that, enjoy. It's totally fine. So guide, I'm going to inspect it, and the guide is going to be delivered to my office. Okay, it's a direct replica of what you're seeing here, just in plastic printed material. You see the tubes. I'll inspect it for any flush material, for stability. And I'm not going to book the surgery until I give this guide to my technician with the fixture mounts, meaning the fixtures, the components that used to deliver the implants through the guide, and the implant analogs. And the technician is going to take the model, take this information, and create a model. Okay, before the surgery is done, with 2 provisional crowns. He was able, based on the position that I showed him, based on the model that he had, it actually showed that the crowns, both crowns, can be screw retained, which is great. So it's a little bit different than the plan. And why is that? How's that possible? It's only if there was a discrepancy, number one, or if the original crown or wax up is not accurate. And I planned off that, but in real life, when the technician comes to make the crown, it's proven wrong. Okay, so there are a lot of variables. There's not one technique in dentistry that doesn't have an inaccuracy. Even an optical scan, supposed to be one of the most accurate things, has an inaccuracy built into that. Okay, just be aware of that. It's just the amount of tolerance that every system has. There's always something that is going to be inaccurate. Okay, and that's pretty much true for almost anything in life. If you look at your practice philosophies and the things that you do, if you had to take out, and maybe at some point, maybe after this training, do a little exercise and think about the things that you do in your practice, whether it's surgical or restorative, and think about the techniques that are 100% successful and always work predictably, 100%, not less than that. You'll pretty much get rid of everything. Okay, there's not one technique that is 100% ideal, that doesn't have any flaws or drawbacks or complications and problems, and surgery is included. Okay, the only thing that is beyond any doubt, you'll just be left with, I guess, math. Math. 1 + 1 is always going to be 2. Okay, to our knowledge today. Okay, but all the other stuff can always be challenged, and even guided surgery. But it's the best we have right now. Okay, our provisional crowns made. Okay, this time we have a timing mark right in here. Remember, we have a timing mark on the guide, and when we connect the fixture mounts, this is what we want to align our guide to. Okay, so we made it very, very clear on the guide. We have 2 provisional crowns for the central and the lateral. Okay, right in here. And here you can see something interesting. Here you can see something interesting for the central incisor. You see that the emergence profile is kind of abrupt. It goes from a narrow platform, from a 4.3 diameter implant, to the circumference of the crown. And it does it, there's not too much running room. So this is like a warning sign, and I should have caught that then. But hindsight is always 20/20. So I looked at it, and only after the case was done, looking into something which I'm going to share with you right now. But that should be a warning sign. The should be something like that, like the see gradually to the emergence profile of the crown, from a narrow diameter implant, from a 3.5 to a crown. Not okay. Warning signs. Open your eyes. Okay, so let's look at the procedure. We're almost at the end of our training here. I like to use the timeout protocol. I mark the tooth that I'm going to be extracting, tooth number 8. Obviously, tooth number 10 is broken down. It's pretty obvious which tooth needs to be pulled. Number 8 was removed with forceps. Okay. Very simple. It was totally resorbed in a lot of caries. But how am I going to extract number 10? Okay, reflective flap. We don't want that. There's not too much grab, not too much tooth structure that I can extract the tooth with. And I'd like to preserve this beautiful tissue. Remember IGR number 2, previous training, I talked to you about the Benex system, the vertical extraction system, and I use it in this case. Why not? This is really a great system where you anchor extraction screw, use a pulley system to pull this tooth vertically. And something that may look like a difficult extraction becomes really, really, really simple. Okay, so it's a great investment. Now, looking at this picture, I'm very thankful that I have at least 2 adjacent natural teeth. This is what's going to support our soft tissue right in here. Implants don't do that. You can tell number 7 is an implant, doesn't do that. So what am I going to do next? I'm going to place my surgical guide and osteotomy sequence. Now with the first drills, and I'm just showing you what's on the screen here, you're looking at direction indicators, and you may be wondering, hey, why aren't these direction indicators right in the middle of the osteotomy? Well, at the beginning, especially for immediate implants, when you do your first osteotomy, the first drills are going to be smaller than the extraction socket. Make sense? And then these direction indicators are not going to be 100% stable. So you still take a radiograph, a verification radiograph, to make sure that you're in the right position. And this is what you're seeing here. Actually, you're seeing the initial twist graph right in here for the number 8 and for the number 10 to make sure that I'm free from the adjacent teeth. And then as I increase my osteotomy, the osteotomy increases in depth and in width. And when I complete my osteotomy, I can place my implants through the guide. Now be very careful when you're placing immediate implants that you don't over prep. You need initial stability. Okay, and that comes from the palate. So good planning, placing the implant a little bit more palatal in a good restorative position is going to give you good stable implants. Okay, so make sure that you're not over prepping, that you take some radiographs during, that you're not impinging on. And when you completed that, only then deliver. And I mentioned to you before, timing is everything. So how do we time? In this case, we time the implants in a way that the tip of the hex is aligned with the timing mark. Okay, some technicians make a groove, a physical groove, or you can make a mark or both, and that's totally fine. That means that this implant is now placed in a, first of all, the fixture mount is touching the tube, meaning it cannot go any farther, go any farther apically, but the timing of the implant, the position of the hex around its axis is also timed properly for both implants, for number 8 right in here and for number 10. I hope this is very, very clear. If something is not clear, make questions. Okay. Now, the proximity to the nasopalatine canal, I looked at the scan. It was pretty close, but it was not in the canal. Okay, you can actually engage the walls of the canal without impinging. It's totally fine, Anthony, because this is a very stable type of bone. It's not the inferior velar nerve. You need to keep, 2 millimeters of distance, but you need to make sure that you're not impinging upon it. Okay, so how close? Pretty close, but not in it. That's totally fine. So here's the final position. Place. The implants are submerged. Okay, fully guided placement. Okay, and the next step, and of course you need to make sure you have enough torque values. Both of these implants went in over 35, over 40. 14 Newton centimeters, which is something that you see on your torque driver. And I immediately place healing abutments just so the tissue does not collapse on me. I fetch the provisional crowns, but remember we have the gap grafting, right? Those implants are placed a little bit more to the palate. There's a gap between the implant body and the buccal plate, which I recommend you graft. And anything that is non-resorbing or slowly resorbing is great. Things like BIOS is fantastic, which is a xenograft, cow bone. But I had the two structure, which I ground down for dentin. Okay, so I use it for the grafting. Graft the gap. It's kind of tricky to graft in there because if you didn't reflect the flap, it'll be kind of bleedy. So I use a little spatula right in here, deliver the graft into the site, and with a spatula, very carefully condense it into the socket, clean out all the excess. Some of those particles will go all over the place, and that's not a good thing. And then, okay, let's try those provisional crowns. Okay, so here's number 10. Okay, looks pretty good right in here, delivered. And I also will take a radiograph to make sure that my implant is well positioned, that the provisional is well positioned in there. And I'm happy with that. And looking at the temporary crowns, I'm looking at 10. It looks okay. You see, it looks okay. It's a little bit bulked out on the buccal, and I guess this is how the technician made it to allow me screw access. But if the contours would be completely flat and matching the adjacent, maybe we would not be able to do that. But 10 is very reasonable. 10 worked out great. But look at number 8. Can you see a problem? Look at this picture. Can you see a problem from this angle? And I hope you do, because I'm looking at it and it looks like the crown is a bit too much to the buccal. And let's look at it from the buccal. Okay, I'm going to give you just a bit. What are we looking at? We're looking at the platform of the platform of the implant is here, but this is still the crown. The transition is visible. What does it mean? It means that the implant is too shallow. It's too shallow. It's too coronal. Okay, so that's a problem. That's a big problem, because let's just think about the following. If I now say, okay, I did a guided procedure, I followed my drills, I followed my recipe, I followed the guide, I placed everything in there, I delivered the crown, it was done by a technician, not my problem, goodbye to you, it becomes a huge problem, because for some reason, this implant was not planned deep enough, or the soft tissue shrunk away at some point, or something went wrong with the fabrication of the guide. I want you to see plan was how this provisional was made. The tissue here was quite bulky. Difference between the tissue here and here, because time has gone by. Maybe the technician used which he used actually. He used the older model, because we can see the provisional crown right in here. What's the conclusion here? What's the lesson learned? What's the lesson that I learned to be better next time around? Get updated records, new impressions, new accurate impressions, new CT scans. Okay, this was a warning sign. This was a warning sign here that the implant is too shallow, and this could be a disaster. So let's see how I manage that. But search after the fact. This implant should have been buried deeper. Okay, you can see it's flush with bone, but this soft tissue here shrunk away, okay, over time. So this implant should have been planned deeper. Now, we can't leave the patient like that, doctor. Don't be blind. Don't get into a bubble or a kind of a blind spot or a tunnel vision. thinking I did everything right, everything should be right, it's all right. No, because if you leave the implant like that, it's a disaster. It will haunt you. You'll have to remove the implant. Okay? That's why one of the first skills that I talked about of being a great surgeon, the 33 steps, the 33 frameworks of being a great surgeon, is adaptability. I see something during the surgery, and my mindset is bring it on. No problem. There was a problem. I'm going to research it later. I'm going to research it later. I'm not going to dwell on it and start crying and go in my room. Okay, that's what kids do sometimes and get into a tantrum. Okay, if you have kids. But there are also some tough kids out there. Okay, like my son. There's a problem. There's a challenge here. Take off this crown. This crown is not going to fit. I need to drive this implant from this position. I need to drive it deeper. I need to drive it deeper. Now, it's going to fit after some adjustments, meaning this implant will be driven deeper. You see it's kind of shallow. Look at how it compares to the adjacent implant, okay? It's actually more coronal than the older implant that was placed a long time ago, okay? Now I'm going to bury it and at least level it, same level. So we have some more running room, and then this provisional needs to be adjusted, okay? So it needs to be redone freehand, okay? Not the end of the world. And sometimes it needs to be readjusted, needs to be remade. Do what you need to do to solve the situation. Don't leave an implant too shallow. Okay, this is something that is not correctable. A nightmare in the aesthetic zone with a demanding patient. We don't want that. Okay, so big lessons learned here. Number one, get updated models. Don't be a hero. Okay, don't be a macho. Maybe I was a little bit of a macho here, and I told the patient, I can just use your older scan. It's still there. Your teeth did not change. The technician used the older model, and that trickled down to the surgery, and the surgery ended up being not ideal for the number 8. But because I'm adaptable, because I know what not to do, and I have the experience, I look at it as a great learning experience for me, and also great learning experience for you. And this patient ended up being very, very happy. Okay, very, very happy, and having those crowns restored, and great final outcome. Okay, so I hope this I hope this case was clear to you. I hope this case was educational, of seeing multiple implants in the aesthetic zone, a canine, okay, number 6, number 8, and number 10. How to deal with an adjacent previously placed implant, dealing with some soft tissue issues, how to plan the case, how to prefabricate a provisional, collaborating with your technician. You don't have to make it chair side. Now, if you want to make it chair side, that's okay too. I don't, and there's nothing wrong with that. And in the number 8 case, we needed to do it, but that's something that was a misplanning on my end, and there was something that went wrong in the process, and that trickled down to the surgery. Okay. Last but not least, I'd like to say how much to charge for CGI. How much to add upon? Do you give it out for free, meaning do you charge for that, or charge the patient the cost of the guide? These guides can be, let's call it $300. Okay. Do you charge double? Do you triple the cost? Do you charge for the time planning? Do you make a big deal out of it? Well, everybody does it differently, but I recommend you charge an extra fee for the guided process. Don't give it away. Something that is not paid for has no value in the mind of the patient. Okay, an expensive car, an expensive shirt has value, has a perceived value. We talked about it in previous training. But this is real value. You spend the time uploading, downloading, you spend the time planning, you spend the time consulting, you spend the time and money in educating yourself. You should be paid for it. You should be compensated for that. The question is how much. Now let's talk about the old world. Okay, the old world meaning using conventional guidance. I'm making a case for computer guided surgery throughout this training. Okay, you have a whole training called CGI Box. Next week we're starting with CGI training live. Okay, CGI Box Live #1 is coming next week. So you need to be paid for that. So in the old world, you would typically charge the patient for a guide, for a conventional guide that the lab made. And here in LA, the average cost of a guide is about $100, $120, around that. Okay, not a big investment to getting your implants placed accurately. Now, for computer guided, there's a lot more stuff. There's a software that you need to buy, and we'll talk about it. There is a time uploading, downloading, the planning. The guide itself is about $300. So I figured out if that. I'll give you a guideline. Okay, we're not price fixing, but I can give you a guideline. You should charge about 2 to 3 times of how much you charge for a conventional guide, at a minimum. Okay, and I actually want to correct that. You should charge 2 to 3 times as much of how much the guide is costing you. Okay, so if the guide is costing you $300, a computer guide, then you charge between $600 and $900, and that accounts for the time, the expertise, the cost, but more than anything, the value that you're providing. If you're delivering a high value treatment, which you're learning how to do, charge for it. What's the point in giving it away? Now, if you have a little bit of fear, oh, my patient cannot afford it, then you're fear driven. Let's work on your fears instead of lowering the fees. It's much easier and better for you to gain the confidence. That's what we started with. That's what we started with in this training. I talked about the 33 steps, the frameworks, one of them being the confidence. Work on your confidence and charge higher fees, as opposed to not working on your confidence and charge lower fees. Okay, so it's impossible to you right now. It's not. It's 100% behind this treatment. If you talk to your patients and you tell them, hey, you're placing an implant in a computer, the only way you'll do this for your patients, and you have many patients that benefited from this type of treatment, and many patients that now can confidently smile and function because their implants were guided in with CGI, your patients will see the perceived value and the true value of what you're doing. And I believe you need to charge at least 2 to 3 times as much as this guide is costing you. So I know the slide says conventional guide, but if you're watching this later, watching this live, you need to charge 2 to 3 times the cost. Okay, and depending where you buy them, leave some comments below this video, leave some comments in the chat when you're watching this live, because this is going to pay dividends, especially in the aesthetic zone. Okay, so I'm going to spend a couple minutes Q&A. If you have any questions, let me know. We have some doctors here in the room. Ask me anything that you want. We're almost done. Some of you guys, it's the middle of the night, so time to go to sleep. Some of you are watching this before work, time off work, that's totally fine. Some of you are watching this as a recording because I'm going to post it in the platform. Again, in Speak CT, there's a section called recorded live training. So you'll have, there'll be all 6 sessions will be there. And like I said before, next week we're starting with CGI Box training live. So I'll talk about all the cases that you're learning how to plan, okay? So Anthony asked me before, how close do you get to the nasopalatine canal? I answered that. You are not inside the canal. You can be close. Try not to invade it because you can damage the nerve. You can create some inflammation and nerve disturbances, okay? Anthony also mentioned for this type of case, yes, you can definitely use a splint therapy. You can use night guard. You can open the bite. You can do a lot of things to prevent these things from happening. But my feeling is this patient that you just saw is going to need more implants. And hey, I'm ready. I'm going to take a new scan and new models, okay? So announcement on the next training, live training number 4 is coming up June 15th. It's coming up this Thursday at 5 p.m. Pacific time. We'll have some doctors from East and West Coast here in the United States. Some people from overseas may have to wake up in the middle of the night, but I promise to divide these trainings into night or afternoon and mornings so we can be fair with all the different doctors that are taking this course. We have a lot of doctors in this training. A lot are taking the live training. Some are watching it later, their convenience. It's totally fine. So Anthony is asking, I've been using your pricing on materials and included the CGI in it. Do you suggest charging for the guide outside the implant procedure? Great question, because you watched obviously the previous training. It's up to you. It's up to you. Let me tell you what I do. I use the formula, but the guided procedure, I call it separate. It's a separate procedure because, you see, we spend a good amount of time, sometimes an hour, sometimes 2 hours, speaking to the technician, working on our computer, working on our software. There's a learning curve. I'd like you to be compensated for that. Now, you have to be reasonable. If you use my formula, and it comes down to that, every implant is $15,000, and you won't have patients to pay for that. So it has to be within reason. That's why I gave you a leeway of plus minus 20%. This is what I would do, Anthony. I would play with the formula, and I would see what it comes down to. And you know your patients best, and you may want to initially say, okay, I'm just using the original formula from IGR number 1 and 2. And I'm going to include the cost of the guide in the materials. I think that's fine for starters, but I'd like you to get to a point where you charge separately for a guided procedure, because then patients know that you are committed, and patients pay for that. I sometimes take patients to the office, exactly where I'm sitting right now, and I open up the software and I show them exactly how I plan it, and they totally get it. Okay, so thanks for this comment. Okay, so let me know how it goes with the fee structure in our next training. So next training is training number 4, June 15th at 5 p.m. And we're going to get started talking about failures, what to do, don't work out. That's actually going to be 3 trainings. IGR 6 are dedicated to complications. What to do when your implants fail. Present with that's an underexplored area in continuing education. And you are undereducated in that. Why? Because implants have hype around them. Implants have all these glory stories and success stories that I'm sharing with you as well. But I'm also going to share with you what to do when those implants fail. Those couple percent, let's say 5% when your implants fail and don't work. How to manage that, how to address that, when to remove an implant, how to remove an implant. Okay, I want you to be familiar with that. I want you to know how to do these things. Okay, so I look forward to seeing you in the next training. I want you to be a confident surgeon. It doesn't happen overnight. You have to have patience, active patience. You need to keep doing, keep working, have a wax up attitude, keep waxing up, keep building your sculpture, keep chiseling away, and build up your confidence. I'm here to help you. Okay, I'm here online and offline. So take advantage of me. Okay, I'm a busy guy. And I have a busy practice, but I take the time. You are important to me. You are important to Surgical Master. Why? Because without you, Surgical Master would not exist. We would be just talking to nobody. But we developed an amazing audience together with my partner, Dr. Rashad Ryman, here on the broadcast. we developed a great audience, and the audience is already segmented into doctors that want to learn more and want to be more and want to be successful. And that's you. And that's you. And I'm giving you most of my attention goes to you. So if you have a question, don't be shy. Put it down in the chat box. If you're watching this later, participate in the live training, ask questions, go to the Facebook group, to the Surgical Mastermind, post cases. Take advantage. Okay, take advantage for of this course, and let me help you in this journey. Let me hold you by the hand. Let me create some clarity. And for the doctors that are participating, and I know this for a fact because doctors are sharing, the learning curve is shortened. You're learning from my mistakes. Even in this case, in this training this morning, I shared with you a pretty good case, and it was successful. Patient was happy. The dentist I was working with was happy. But there were a couple of kinks, a couple of problems there that hopefully we can all learn from. I definitely learned myself. Okay, so until the next training, keep learning, keep practicing, keep getting better, keep excelling. You can do surgery, you can perform surgery at a high level like an implant specialist, like a periodontist, like a surgeon, better many times. Better than a surgeon, better than a periodontist that is not utilizing this technology. Okay, you can beat a surgeon placing implants for 30, 40 years in terms of accuracy and precision if you're using guided surgery. And the other surgeon, if the other surgeon is at their top of their game, okay, and I'd like to be the top of my game, it'll be hard for you to beat. It'll be hard for you to beat because if you're dealing with competing against a surgeon that has not only training, the surgical training and all the experience and the confidence and all of the above, but also using technology like we're talking. That's the ultimate surgeon, but don't use this technology. I don't know why. It's the ego, okay? So have an amazing advantage, definitely over your peers, and definitely specialists that are not using this technology. So take advantage of the implant gold rush. Okay, so on that note, I'm going to see some patients. I'm going to go in there confident, treat my patients, place some good implants, and I'm going to see you in the next training. We're going to talk about complications, what to do next. Okay, to your surgical success, Ziv Simon, I'm signing off. Have a great day, great night. I love teaching you. I support you. I congratulate you. And I'll see you soon.